Hospital, Imperial University of Medical Science. We discussed in 4 classes with you about cell injury and voluntary effect. Okay? In this chapter, we discussed about cell injury, cell death, and adaptation. We discussed about cell injury. But this is your reference book. I recommended to you read the reference book because the reference is very useful for you. Discuss all of content very good, and it's very useful for other examination rather than final examination. For example, Pranterney Ulmikaya as a general examination for you, and recommended to you read the reference book. But I reviewed the 2 contents, and I tell to you all of the important content of this book. This book is 11th edition, 2023. Your examination is from this book. Okay. We discussed about pathology. 2 items is very important, and we discussed about etiology and mechanisms. But what is etiology? Do you know? Okay. And what is pathogenesis?
It's the mechanism.
How any microorganism cause disease.
Okay. Mechanisms.
The reason of the disease.
All of the etiologic agent causes disease, causes symptom, and sign in a patient. Pathogenesis describe how a disease progresses. In our world, we have etiologic agents. Etiologic agents are very various. For example, we see some of etiologic agents, such as hypoxia and ischemia. It's very common. You see and you hear very ischemic disease in around of body. For example, myocardial infarction is very common. Cerebral vascular incidence, CVA, is very common. So, hypoxia and ischemia is etiologic agent in this disease and many diseases. And also toxin, infectious, abnormal immune system, nutritional imbalance, genetic abnormality, and physical agent. As we see in this slide, etiologic agent causes disease. We have pathogenesis. Pathogenesis is composed of biochemical and structural change in the cell and in tissue. And we have abnormality in level of molecular, functional, and morphology. And ultimately, clinical manifestation with special sign and symptom is occurred. So, we discussed about cell injury. We review level of cell injury. We have healthy cell or homeostasis. What is homeostasis?
Maintenance of bodily function.
Okay. And other response?
Maintenance of constant body function as compared to the environment.
Okay. And what's difference with hemostasis?
It's about the blood. It's related to the blood.
Hemostasis rather than homeostasis. Homeostasis is okay.
Homeostasis is regarding the cell.
Yes.
Homeostasis is about constant body temperature, osmosis descendant. About him, I think it's about rare disease.
Okay. Then we have discussed about homeostasis is a stable internal environment. Despite internal and external stimulus, okay? But when we discuss about hemostasis, it's stopping in bleeding, okay? This term are similar and in some situation mistake. But you learn, we discussed about homeostasis, a stable internal environment. So after injurious agent in a healthy cell, the first when injurious stimulus is mild or injurious stimulus is transient, we have reversible injury. After severe etiologic agent, severe stimulus injurious or stimulus injurious became progressive, we have irreversible cell injury. In irreversible cell injury is point of no return and we have cell death. We have two common patterns of cell death, necrosis and apoptosis. We discussed about all of morphologic pattern, reversible injury, irreversible injury, necrosis, apoptosis, morphologic change, and also pathogenesis. So, in this slide, we again review etiologic agent. Oxygen deprivation, physical agent, toxic, infectious agent, immunologic reaction, genetic arrangement, nutritional imbalance, and physical agent. All of them are very common in our environment. The first we discussed about oxygen deprivation. We have two terms when we discussed about oxygen deprivation, hypoxia and ischemia. What is different between hypoxia and ischemia?
Hypoxia is deficiency of oxygen, but there is a little.
Okay.
But ischemia, there is no any oxygen.
There is no only oxygen and
cell death and like fibrosis, cirrhosis,
Okay.
fibrosis.
okay. In ischemia, we have loss of blood supply. Okay. We lost oxygen and other nutrients. For example, glucose and other needed nutrients. So, ischemia is severe, has severe damage rather than hypoxia. And the most common etiology of hypoxia is ischemia. Do you know what etiology can be hypoxia without ischemia?
Yes, if there is lung infection, like
Lyme disease, okay? And toxicity with monoxide carbon or lying in high, yes. But in ischemia is severe and is the most common cause of hypoxia. Okay, we have many physical agents. For example, mechanical trauma, temperature, burn, and also deep cold, sudden change in atmospheric pressure, electrical shock, and radiation. Chemical agent. We have many chemical materials are necessary for us, but for example, glucose in high level, on very low level, oxygen in high level or low level are toxic, and also some social stimuli such as alcohol, narcotic, and some fluent in in our environment are very toxic for our body. And poison, for example, cyanide, arsenic, mercury, are very common in industrial living and are dangerous for a healthy cell. Also infectious agent. The most common infectious agent in 5 years ago, for example, corona, with high mortality and morbidity. So we have virus, we have fungal element, parasite, and we have bacterial element are pathogen for our cells and body. Okay. And also immunologic reaction. Immune system is necessary for our body, okay? But in some situation, for example, anaphylactic reaction, anaphylaxis to some drug, for example, anaphylaxis to penicillin, anaphylaxis to some drug, to some fruit, and some food has very dangerous symptom and associated with high mortality. And also, immune system for defense, but in some situation, immune system active against ourselves, and we have production of many autoantibody, and we have autoimmune disease. For example, arthritis rheumatoid, lupus erythematosus, and some diseases. Genetic derangement, Down syndrome, and sickle cell anemia. What is etiologic agent or mechanisms of Down syndrome? Okay. Extra chromosome. Okay. Which chromosome?
21.
21. Okay. We have other extra chromosomes. For example, chromosome 13, chromosome 18, but Down syndrome with trisomy 58 are alike trisomy. Okay? But in some situation, we have only some situation of one loss in sickle cell anemia and one amino acid transition. For example, glutamic acid replaced by valine, and we have sickle cell anemia with many symptoms and sign and early mortality. Also, we have nutritional injurious agent. We have underweight and overweight. We have caloric protein malnutrition in some situation, and also in industry country we have excess of calorie, excess of lipid, predispose people to diabetes mellitus, obesity, and atherosclerosis. So we discussed the first about reversible injury. In this figure, you see healthy cell convert to the injured cell. But in this stage, it's reversible. So if you remove etiologic agent, the injured cell return and recover into the healthy cell. So what you see in injured cell, cell became larger, okay?
Yes.
Cell became larger and swollen. Also, in nuclear material, we have clumping of chromatin, condensation of chromatin material. Also, we have cytoplasmic accumulation of water, reticulum endoplasmic swelling, mitochondrial swelling, and presence of amorphous material in the mitochondria. attachment of ribosome from reticulum endoplasmic and presence of cytoplasmic belly. All figure you see, all morphology changes you see are reversible if etiologic agent is removed. We have two forms of reversible injury in the cell. It's hydrophic changes or cellular swelling and fatty changes. In cellular swelling, we have accumulation of water. Cell becomes swollen due to accumulation of water and sodium. And in fatty changes, we have accumulation of cytoplasmic fat in the cell. We discuss later about this. So, in cellular swelling, cellular swelling is called hydrophic changes, vacuolar degeneration, because we have water vacuole in the cytoplasms. The first manifestation of almost all form of injury to cell. So, is first and is common after etiologic agent. But it is difficult to microscopic examination. The organ became swollen, larger, and in microscopic examination after hydrophic changes, this is a macroscopic examination, for example, pale kidney after reversible injury, and in microscopic level, we have accumulation of many clear vacuole in the cells. In this figure, you see in this glomerular, the top, we see normal glomerular, but in the tube, we see many accumulation of many water, clear vacuole due to accumulation of water. So, the most common reversible morphologic changes is hydrophic changes after accumulation of water in the cells. So, then we discuss about reversible and irreversible injury is dependent to the type of tissue. For example, the most common ischemic changes in our body is myocardial infarction due to loss of blood flow in the cardiac muscle. In cardiac muscle, in 20 or 30 first minute, we have reversible injury after blood loss. Okay, after blood, no blood supply. 20 or 30 minutes, we have reversible cell injury and cell function is decreased. For example, contractility in muscle is decreased. After 30 minutes, we have irreversible injury and cell-less is occurred. But morphologic changes, ultrastructural changes in electron microscopy seen only after 2 or 3 hours, and in light microscopy after 6 or 12 hours, and macroscopic examination in the cardiac muscle show necrosis after 2 or 3 days. So, the first morphologic manifestation is seen in ultrastructural study. Okay? This is very important and it is a question for your final exam. Okay, what is irreversible injury? In this figure, use a cell is very disparate. For example, plasma bellet, irregularity, plasma membrane rupture, mitochondria swollen and calcified, nucleus is fragmented and irregular, and aggregation of skeleton and intracellular protein. This slide is very important for understanding and your final examination. We have 3 phenomena for irreversibility. Three phenomenon in three organs. Inability to correct mitochondrial dysfunction. When we see irreversibility associated with inability to correct mitochondrial dysfunction, we have loss of ATP and ATP production. Also, loss of structural integrity of DNA chromatin and profound disturbance in membrane. So, mitochondria, DNA, and membrane are very important for starting in irreversible damage. In this figure, we see healthy cell, reversible cell injury, and irreversible. We discussed reversible cell injury, but in irreversible cell injury, as you see, we have rupture in plasma membrane and rupture in organelle membrane, also fragmentation of nuclear material and failure of nuclear material, fragmentation of mitochondria, swelling and cystic changes in reticulum endoplasmic, detached ribosome, and accumulation of water in the cells. Also, in necrosis, when we have cell death with necrotic pattern, we have accumulation of inflammatory cell around the necrotic area. So, when we discuss about cell death, we have two common patterns, necrosis and apoptosis. We discuss about necrosis. Necrosis is accidental cell death. Okay? In necrosis, the most common morphologic changes is loss of membrane integrity and leakage of intracellular content to out of cell. So we have inflammatory response. After inflammatory response, for elimination of necrotic cell, we have repair and fibrosis. When we discuss about morphologic changes in necrosis, two patterns are very common. The first, the maturation of intracellular protein and enzymatic digestion of cell. The source of enzyme is intracellular lysosome, activation and rupture of membrane and release of enzyme. And also we have immigration of many leukocytes in necrotic area. In this area also we have many enzyme and enzymatic digestion occur due to activation of such enzyme. Okay, what's morphology changes in the necrosis? In necrosis, we have increased eosinophilia. We discussed. In necrosis, we lost nuclear material. When we stain tissue with hematoxylin and eosin, hematoxylin show blue color in the nuclear material, color with hematoxylin, and protein color with eosin and became pink. Okay? In necrotic cell, we have increased eosinophilia because in necrotic cell, we lost basophilia due to loss of DNA. DNA fragmented and failed. And so we have increased eosinophilia. Also, the naturated protein 10 attached to eosin and became pink rather than basophil staining. Also, we have glassy hemogen because in necrotic cell, we have loss of glycogen. And due to enzymatic digestion and digested cytoplasmic organelle, we have vacuolated cytoplasms. Its name mouse-eaten. And calcification is the ultimate change in the dead cell after removal of necrotic cell. We discussed about calcification in last session. So, in this figure, as you see this figure, it's a kidney. The center is glomerular and the peripheral is tubule. What's necrotic segment? Tubule or glomerular?
The pupils,
Tubule. Why?
because they're enlarged, swelled.
Okay. In tubule, we lost basophilia. Okay. It's eosinophil due to loss of nuclear material. But in the glomerular, we have increased basophilia, dark blue in the nuclear material, and cytoplasm is eosinophil. Nuclear changes in the necrosis, normal situation. The first, we have pycnosis, condensed and clumpy chromatin in pycnosis. After that, we have choriorexic, fragmentation of nuclear material, and choriolysis. Due to activation of DNAs, we have loss of nuclear material. So, basophilia is lost in hematoxylin and eosin staining, and increased eosinophilia due to the denaturated protein in the cytoplasm. We review nuclear changes, pycnosis, choriorexic, fragmentation, and choriolysis due to activation of DNA's activity and other enzymatic digestion. Okay, after a time of necrosis, necrotic cell may persist for a cycle, for example, 2 or 3 days. After that, phagocyted by many inflammatory cells and digested. We have myelin figure and other, and they phagocyted by other cells, and ultimately we have deposition of calcium salt and calcification is occur. It's called dystrophic calcification. We discuss later. We have many patterns of necrosis. In this chapter, we discuss about common pattern: coagulative necrosis, liquefactive necrosis, gangrenous necrosis, caseous necrosis, fat necrosis, and fibrinoid necrosis. They have morphologic changes in this pattern are different. Coagulative necrosis. Primary pattern is denaturation of protein. In liquefactive necrosis, the dominant pattern is enzymatic digestion and liquefaction is occur. We discuss about morphologic changes in necrotic pattern. Coagulative necrosis. This coagulative necrosis, as you see in previous and last slide, cell have died, but basic architecture of cell present for few days. So organ shape is present in coagulative necrosis. Affective tissue maintains solid consistency. Ultimately removed by inflammatory cell, and after the fibrose and repair is occurred. But in the 2 or 3 years, configuration of cell is present. In this slide, you see, in this figure, you see a live cell. Architecture is cytoplasmic membrane and nuclear material. In the necrotic cell, with loss of nuclear material, increased eosinophilia, but shape of cell is present. Okay, cell is necrotic, but present its shape. In coagulation and necrosis, dominant pattern is denaturation of structural protein and enzyme. Then we have denaturation of an enzyme, enzymatic digestion for few days is blood. We have eosinophilic enucleated cell, but cell shape is present. In this figure, we see in necrosis in the ventricular valve after staining. When ischemic cardiac muscle stain with a special staining in gross examination, the site is alive, is red coloration, and site are necrotic, don't stain, and became yellow to brown discoloration, is in favor of necrotic area. What's seen in necrotic cell in microscopic examination? This figure shows normal cardiac muscle. We see eccentric nuclear material with basophilic dark blue staining, intercalated disc, and cross striation in the striated muscle. After necrosis, we have increase of eosinophilia, pink discoloration. We lost cross striation. We lost nuclear material, and we have accumulation of many inflammatory cells to necrotic area. This is also kidney coagulative necrosis. Kidney coagulative necrosis due to ischemia in branch of kidney artery is wedge-shaped, has a base in periphery and apex in the center. Microscopic examination show tubular necrosis. We have loss of basophilia in the tubule rather than glomerule, but shape of tubule is present. Its pattern in necrotic due to coagulative necrosis. When we have ischemia and hypoxia, ischemia is common. We have coagulative necrosis in all of tissue, but we have one exception. One exception is brain. Brain, after ischemia, don't have coagulative necrosis. In brain, after ischemia, we have other type of necrosis. It's liquefactive necrosis. Its etiology is unknown. So, the first pattern is liquefactive necrosis. Liquefactive necrosis occur in bacterial infection, fungal infection, and few parasitic infection. Because in microbial infection, we have accumulation of many inflammatory cells and enzymatic activation. And enzymatic activation liquefy the tissue. And liquefactive necrosis is occur because the tissue has liquid viscous consistency. Digestive tissue removed by phagocytes is different the naturation in coagulative necrosis. We discussed brain is an exception. In ischemic changes, we have liquefactive necrosis. You have experience about, for example, acne. When you open the head of acne, we have exit of pus. Pus is liquefactive necrosis. Okay, and in the brain, with unknown etiology, after ischemia, we have liquefactive necrosis and cystic degeneration because the tissue became liquefied and not present the shape of tissue. This figure compares liquefactive necrosis in the kidney rather than coagulative necrosis. The left side is coagulative necrosis, and this slide we see liquefactive necrosis. In liquefactive necrosis, the shape of tissue is removed. Also, we have gangrenous necrosis. Gangrenous necrosis is a coagulative necrosis. Gangrene is a clinical item when we have full thickness ischemia in the tissue. We have dry gangrene and we have wet gangrene. Dry gangrene is coagulative necrosis when we have superimposed with inflammatory cells and microbial agent. We have liquefactive necrosis and wet gangrene is occur. It is dry gangrene after ischemia in diabetic foot, in Berger, and emboli in the artery in the foot. We have full thickness and black discoloration in the tissue. It's dry, and in this pattern, coagulative necrosis is dominant. But when we have ischemic necrosis in the intestine, the first coagulative necrosis is occur, dry gangrene. But in the intestine, we have many accumulation of bacterial agent, and due to bacterial infection, wet gangrene became dominant and oozing of material, for example, occur in intestine, appendix, lung, and uterus after accumulation of inflammatory cell and microbial agent. The other pattern is caseous necrosis. Caseous necrosis is coagulative necrosis, but the shape of organ is not present. Caseous because we have cheesy cream material in the necrotic area, and most common etiologic agent is tuberculosis. Then form granulomatous reaction. In this figure, we have caseous necrosis, cheesy material, material are fragile, cheesy and white discoloration in the central granuloma, in the lung after TB infection. Or also we have coagulative necrosis as caseous necrosis in the lymph node in the hilum of lung after TB infection.
We don't have treatment for this just cut.
TB
Treatment for this gangriosis. Just cut the part is damaged.
I don't understand your question.
Like this, the foot is have damaged gangriosis. The foot from diabetic. We don't have treatment for this for the condition. Just
Dry
cut.
gangrene.
Yes, we don't have treatment.
Yes, have treatment. But have prophylactic treatment. When gangrenosis occur, an amputation of the tissue and organ is a treatment. But we have many modality before full thickness gangrene or full thickness necrosis is occur to prevention of necrosis is occur. When we have necrosis, removal of tissue is a treatment only,
Just
unfortunately. We have morphologic changes in granuloma. We have caseous necrosis, accumulation of many histiocytes surrounding necrotic material. Also, we have multinucleated Johnson due to joining of epithelioid histiocyte and chronic inflammatory cell such as lymphocyte and plasma cell. With high magnification, we have necrotic material, okay? Histiocyte, epithelioid histiocyte, multinucleated Johnson, and accumulation of lymphocyte and histiocyte. It is dominant pattern in the caseous necrosis with tuberculosis. It's characteristic for tuberculosis. So we have fat necrosis. Fat necrosis, as you know, is necrosis of fatty tissue. We have two types of fat necrosis, traumatic and enzymatic. For example, trauma to fatty tissue in the subcutaneous fat, in the breast, after surgery, after trauma. And in some situations, enzymatic digestion due to inflammation of contrast and release of lipids because digested fatty tissue and accumulation of inflammatory cell surrounded necrotic fatty tissue is a hallmark when histologic changes. This figure, you see arrow, histiocyte surrounding the hollow space. When we process the tissue exposed to other chemical materials such as gazidol. Gazidol dissolve fatty tissue, and we see only a hollow space without any material surrounded by histiocyte, and then the video figure stained with oil red oil, we have red discoloration is characteristic for fatty changes or fatty tissue when we have problem with diagnosis. Also, in pancreatitis, we have fat necrosis, fatty acid is released, calcium is deposition, and we have fat saponification in the tissue. In macroscopic examination, for example, in the surgery after pancreatitis, we have fat necrosis in the omentum and chalky white area due to calcification of fat necrosis is seen by surgery. Also, we see fat necrosis and calcification in macroscopic examination. Microscopic examination is digested fat hollow space surrounded by inflammatory cell, and also calcification is occurring. We have yet another pattern, and we have a bird. Don't worry. The last necrosis is fibrinoid necrosis. Fibrinoid necrosis is occurred when we have aggregation of immune complex and attached antigen, antibody, and deposition in the arterial wall. It's fibrin-like, so-called fibrinoid necrosis in hematoxylin and eosin. Deposition of fibrinoid eosinophilic material in the arterial wall associated with some vasculitis, for example, prearterial necrosis and HON. In microscopic examination, it's luminous vessel filled by RBC and deposition of amorphous eosinophilic material and infiltration of many inflammatory cells. Its dominant pattern in fibrinoid necrosis in the vessel and associated with secondary hypoxia and coagulative necrosis in the tissue. Have a 10-minute break and then return after 10 minutes.
Thank you, sir.